Up next, a closer look at the issues explored in the KUED documentary On the Edge. A phone bank of experts standing by to respond to your questions relating to mental illness, and free packets of information to better understand mental illness, treatment options, and the often confusing mental health care system in Utah. And I'm Ken Verdoya. For more than a year, my colleague Nancy Green has been examining the complexities and contradictions associated with mental health care in Utah. In the simplest sense, she discovered tens of thousands of Utah families have something very sincere, very pressing, very personal in common. They're responding to a serious mental illness in the life of a family member. She also discovered a system of care for the mentally ill crippled by inadequate resources, disconnected programs, and broken promises. Yet at the same time, she discovered a system punctuated by innovative, progressive treatment opportunities that demonstrate the possible, but only address a fraction of the need. This is all so compelling. The result is her important documentary, On the Edge. Now, after watching the program, you may very well have some questions about where you or a family member might turn for guidance in responding to the challenge of mental illness. That's what we hope to address in the next 30 minutes. Here at KUED, we've set up a phone bank. A number of well-versed volunteers are standing by to respond to your specific questions about mental illness and the challenges of navigating your way through the mental health treatment system. Now, in addition, our volunteers can send you a packet of information absolutely free. And in this packet, you'll receive a copy of the KUED documentary, On the Edge, information about mental illness and about Utah's mental health programs, support groups, and the best sources of information available in the state. Now, you can call us anytime during this program at 801-585-LINK. That's 801-585-LINK. It also translates numerically to 801-585-5465. You can also access this information on our KUED website. It's found at kued.org/ontheedge. Remember, the information packet is absolutely free. Our volunteers will merely ask you where to send the material. And if you do have a question about mental illness or find yourself facing a challenging situation, we have trained responders standing by to help. The number, once again, 801-585-LINK. In the studio, I'm joined by three experts with rich experience in responding to mental illness and creating pathways for treatment and recovery. Sherry Whitwer is the Executive Director of the Utah chapter of the National Alliance on Mental Illness, sometimes better known as NAMI. Dr. Doug Gray is a board-certified psychiatrist and associate professor with the University of Utah Health Sciences program. And Stacy Brubaker is the Associate Director of Specialty Services for Valley Mental Health, a major mental health care provider in the heart of the Wasatch Front. Ladies and gentlemen, the pressing issue that jumps out from Nancy Green's documentary On the Edge is one of access and the lack of access to quality care. Not that care doesn't exist, we don't know what to do, we just can't get people there to do it. Sherry, why does this exist?
Well, you know, we have issues, first of all, with insurance, where mental health treatment is not typically covered on par with physical illnesses. There's been a federal parity law that has been passed, but we're yet to see how that will really translate. So in reality, I would say most of us are underinsured for mental health treatment. And should there be a mental health crisis, it's not long before there's a financial crisis as well. So that's one issue. Another issue is just our uninsured population, those people who do not qualify for Medicaid and cannot be typically treated, although on a limited basis through community mental health, they tend to fall through the cracks as well.
Now, are we talking about a couple of hundred people? A couple of thousand people in a state the size of Utah with a population in excess of 2 million? How do we get a sense of the number of people that have that need? Stacy, have you given that any thought? How can we get our hands around this issue?
Well, I don't know the exact numbers for the state. I know that in my position, we turn away a lot of people not necessarily just even because they don't have the Medicaid. We serve primarily Medicaid people that qualify for Medicaid, but just the resources aren't there. I supervise the Children's Case Management Unit, and we only have 3 case managers to serve the 4,200 kids in our system that we serve yearly. So if a child needs those kind of services, needs an advocate in school, needs to make sure the school is complying with the special needs that come along with mental health issues in that kind of environment, case managers go in and try to do that. We link them up to services. But when you have 3 case managers trying to serve that many kids and families, the resource just isn't there.
Dr. Doug Gray, you are triple board certified, childhood, adolescent, and adult psychiatry. Yes. Is that correct? And you've also have a professional specialty in suicide, understanding its roots, its causes, and the way it is involved with mental illness. You had an innovative program at work where you were working with the juvenile court system, and this really speaks to me in a compelling fashion about the notion of access and being able to sustain what we know what works. What's happened to your program?
Well, we followed, first of all, the kids that died by suicide in Utah. We want to know where they were in our state. And we found out one of the points of access is the juvenile courts. The juvenile courts, they care about kids, but they don't have any money or any mandate to take care of mental health needs. That's not their normal job. But they allowed us to go into the court system and to study kids at risk. And we found out that the mental health of the kids in the court system is very poor, very poor. We then designed a little pilot program to show that we could actually treat kids in the court. We provided free psychiatric care and in-home services, case management. It was a great little program. And we showed that the kids who got the program, their mental health improved. They stopped offending and left the juvenile court system. And this is what was the shocker. It actually saved money. But you have to put a bunch of money in up front early. The people in the courts loved our program. We had a grant. The grant ran out. And they wanted to sustain that program, but they're hit with budget cuts now, and this isn't the time when they can do that, so we've shut the program down. However, I can tell you the administrators at our court system really care about kids, and if our economy rebounds, I think they'd like to get that program going again.
Let me offer my own disclosure of a conflict of interest at this point. And the conflict of interest is an interesting one which shows a little bit of my personal experience. I had a very, very close family member who was diagnosed with serious and persistent mental illness in her life, and that made it part of my life growing up. And it's something that's informed and graced my life over these past 5 decades that I've been aware of. But I do recall one thing from my personal experiences. Once upon a time, if a person was mentally ill, they were likely to be institutionalized. They would find themselves in a state-operated hospital setting or sometimes a private sanitarium setting. We changed the labels over time. But in the 1970s, I seem to recall a great wave of humanity saying, we owe these people better than this. We're better than just locking people away. We've made such progress. We're on a new day. What happened to that wave that was cresting, Sherry, about discovering a new day for responding to mental illness?
Well, that funding, they closed those institutions, many of them, most of them, but that funding never followed to the level that it was supposed to for community mental health. And so what happened is we had people end up living on the streets, end up in the criminal justice system. And we know that that is the primary treatment provider now, is our criminal justice system, which really is a commentary on where our mental health system is today. I think this is the frustrating aspect, and Doug's example with his program is typical. We know what to do. We know what works, but we don't have the funding, or we're not coordinating care. We're not building those community services that we know keep people in their communities, are better for individuals with mental illness, better for their families, and far more cost effective.
Dr. Gray alludes to it, but Stacy, I want to come to you because your emphasis really is on childhood and early intervention. What difference does an early, I mean, this may be the most obvious question of all. Early intervention is always better in any medical setting, but it seems to be even critically more so in a mental illness setting.
Well, I think the earlier you can catch things like that, the better. I think one of the biggest things we have to address is helping parents be on board and getting them the support to be able to support the child of theirs that has the mental health issue, as well as the other community partners such as the schools. There's huge stigma in the schools. A lot of people don't like to deal with the kids that have that label. They have to have special services sometimes to be able to manage their behaviors. School system is full, as we all know, and to throw in these additional problems become an issue. But there are services out there. Again, it's the number of slots that are available to people. We've tried to do some kind of creative things to really help keep these younger kids in their homes so that they're not being bumped to the state hospital or to higher levels of care. Again, those programs aren't the kind of programs that when you look at them on paper, they're not really sustainable over time because of the costs they have, and there's no reimbursable service because insurance isn't going to pay for that. So we have our kind of our own version of a higher level of care that is our most intensive service for kids and families, with the point being keep them in their homes, keep them in the community, keep them in their school if you can. And it's a whole team that wraps around these 12 to 13 kids and families to really try to provide the supports. But again, it's kind of a cutting edge program. There aren't really a lot of them around the country. It was kind of Sherry and I and some other community partners, the county, and then Valley Mental Health said, yeah, we want to give it a shot. And we've had some really good outcomes, but bottom line is slots are limited, and again, the money just isn't there to pay for those kind of services. It goes to other priority needs, or at least what other people perceive as the priority needs where money should go.
Let me just say that the documentary and our discussion may prompt some individual questions that may exist in your mind. I want to remind you that our phone lines are open at KUED. If you would like to receive the free information packet on mental health care in Utah, remember, it includes the KUED documentary On the Edge, produced by my colleague Nancy Green. It's available at 801-585-LINK. That's 801-585-5465. This 30 minutes is an opportunity for you to call in and receive this without any questions asked. We'll just ask you for your address. We'll send it out for you and your family's benefit. If you have a question, more specifically about responding to a person challenged by mental illness, we have trained responders standing by in our other offices. They will take your calls. They'll do their very best to hopefully direct you to a point at which treatment or additional resources may be found. This then seems to be the question of those with the greatest resources will get exceptional care. Those with absolutely no resources may have an opportunity through federally supported programs to get care, but it leaves a large chunk of the population, Doctor, it appears, right in the middle of our economy, our culture, our society, that doesn't have an easy pathway for access to care.
We have a backward system. Any hospital in the United States, if they admit a lot of patients to the inpatient units, they can make money. Every time they open up an outpatient clinic, they lose money. The bigger their outpatient clinic, the more money they lose. So, you know, there are a lot of good people out there trying to create outpatient care, but it's a money-losing entity, and so it's very hard for hospitals, even out of the goodness of their heart, to expand those services, when it means on the other end, the one part of the hospital system everywhere in the U.S. that makes money is the inpatient unit. And so what a lot of these systems use the profits from the inpatient unit to then fund the outpatient care. It's a very difficult situation. In other countries, all the other industrialized countries, they have a national health service and a national mental health service. And what's real interesting is they really get into prevention. And as you get into prevention, mental health becomes a larger percentage of the money that's spent because it prevents all kinds of other problems. But see, today's insurance companies, they're only insuring you or me for a few years. They're looking at the short term only. But if you know you're insuring somebody for 30, 40, 50 years, now you become very concerned about prevention. It's a different model.
Sherry, I would imagine there's a man or a woman sitting at home right now who's deeply troubled, who may see behavior issues, or maybe even already having incidents where law enforcement is involved with a son or a daughter, or maybe it's a close friend that they're talking about. And that person is uncertain and literally can't find an easy yellow page listing of where do I go for help. If that person's sitting home right now, what's the first thing they need to know or consider doing if they're part of the intimacy of responding to mental illness?
Well, you know, first, they can talk to their primary care physicians and say, here's what I'm dealing with at home, here's what's happening, can you help me with this issue, or help me know how to access care. School psychologists are great resources to help families learn how to access care. People can call NAMI. We will help them look at their insurance policies and see what their benefit is and where they can go to get help. They can call their community mental health provider. County-run system, sometimes they cover several counties or a few counties in one area, but there is help out there. There are crisis lines out there that people can call to get answers to some of these questions.
But isn't, and I'll just kind of throw this out and ask any one of you to respond, but isn't it true, as kind of depicted in the documentary, that the great mental health access point right now turns to be law enforcement and corrections, increasingly?
It's a crisis-driven system. It really is, and that's why we know the answer is early intervention in the programs that both Stacy and Doug described, but as budget cuts are made, it becomes more and more that we can just fund the crises, and that's where we turn to law enforcement and the criminal justice system to take care of the problem. It doesn't take care of the problem, doesn't solve the problem. It, momentarily puts the person out of sight, out of mind, but it doesn't solve the problem for anyone.
Is that an expensive method of trying to forge a solution?
Hugely expensive. It's not cost effective at all. And so we know we are spending the dollars, but we're spending them in all the wrong places. We can get a much better return on our investment if we would focus on prevention, early intervention, and access.
How are we doing in terms of forging progress against the stigma that's associated with mental illness? Again, going back to younger days for me, I remember the promises of new enlightened understandings and new enlightened community-based programs, but that was all predicated on being able to get the public to get their heads around the notion that mental illness was something that could be understood and shouldn't be kept shuttered behind literally locked doors. How are we doing?
Well, I would hope to think that we have made some gains, but just like in the documentary when they're interviewing the young lady, she talks about how people find out her diagnosis and they don't want their kids to be around her. They think it's contagious. They think that she might go off on her kids. And again, I've primarily worked with young people, and they really don't want people to know. And even though you talk about it and you try to put it in the context of, you need to take your medicine just like you would if you were diabetic. If you're just, that's not how community sees it. That's not how these young people see it, because they cannot handle the stigma that comes along with it. And kids can be pretty mean, and adults too. And we cast our own judgments on who we want our kids to be friends with and who we don't want them to be friends with. And I can see how it's real, but I would like to think that we have made some gains in that, and NAMI does a lot about that. We do a lot of that with our youth groups. We really try to promote anti-stigma. But again, I think it's an uphill battle, but I think there's hope, and we make small gains over time.
Well, let me, before we go back and get further response on that, let me just once again hit the availability of our free information packet this evening. Remember, our phone lines are open at KUED. Please give us a call. Receive this free packet of information, which contains the KUED documentary On the Edge, produced by Nancy Green. It also contains contact points, information resources on how to deal with an emergent or literally an emergency situation related to mental illness, and also access points for additional information, including contact points for NAMI and Valley Mental Health and other resources throughout the state of Utah. By the same token, that if you have a pressing question and you feel you need to speak with someone right now about responding to a mental illness challenge, we do have trained responders in that phone bank as well. So the number, once again, 801-585-LINK. That's 801-585-5465. The consequences of the stigma, Doctor. When you talk about your study associated with studying suicide, certainly the societal pressures, the ostracism must weigh heavy on young lives that are struggling against mental illness and struggling to find their own way. Do you see that manifest itself, I would imagine, somewhat routinely?
Well, in our suicide study, we looked at 151 youth suicides, and we sought out parents, relatives, friends, school teachers who had experienced a teenager that they knew that suicide, try to figure out what was the biggest barrier between that, kept that person from getting help. and it turned out it was stigma. They were embarrassed about having a mental illness. They didn't believe mental health treatment would help. So the kids that are actually getting treatment, they don't commit suicide. That's quite rare. It's the kids that are mentally ill that don't get treatment. That's the big problem. And there's publications nationally, studies that are done that show that the kids that really can't quite afford care, don't have access to care, they're being shunted into the juvenile court system. And I did a survey in Utah of all the kids going into the system for a month, and 50% of them were over the cutoff where they should have an outpatient evaluation, a psychiatric evaluation. And 17% were over the cutoff for an evaluation to be admitted to a hospital. Now, if you go out in the general population, the bar graph says, it doesn't show anything because it's less than 1%. But it's 17% of these kids in the court system on a mental health screen, they're over that cutoff criteria for being evaluated to be in the hospital. So that gives you a sense of how the mental health system is the kids are being shunted. It's not there, so they're being shunted into the courts.
One thing I learned from my personal experience is that when there's a diagnosis of a serious persistent mental illness, we're all in this. The family becomes diagnosed because the family is literally, whether it's a emergency situation that presents itself where law enforcement is involved, we are all part and parcel of this. Sherry, I know you understand this not only from an organizational standpoint, but from a personal standpoint as well. What do the families need? I mean, it seems to come in so many different forms because I don't know where to turn. I don't know where to start. I don't know how to pay for this. I don't know if I can get through another day without a break unless I get some respite association. Right. What do we need to do for our families?
So what is so tragic that I see and that I have experienced is when there is a mental health diagnosis in a family, and make no mistake about it, it's never, well, that person has this illness, but the rest of us go on and live our lives. There is an impact on that entire family. And families tend to isolate. They feel a lot of shame. They suffer alone, and it's exactly what they don't need at that time and what they should not be doing at that time. They need support, they need understanding, they need education on the diagnosis. What is the prognosis? What does this mean? How can we best help our loved one? How can we take care of ourselves in this process? So it can have a devastating effect on families unless they get that support and understanding.
One thing that I've heard repeated time and time again, in fact, was even reflected in the documentary, that if my daughter had broken her arm, my neighbor would have been first in line bringing dinner to me and my family to get me through the difficulty of dealing with the broken arm. But because my daughter was diagnosed as being clinically depressed, everybody pulled away from me in my neighborhood. That seems to call to the better angels of our nature among ourselves, that this is not a government program that we need in place, but we actually need a little bit more of a clear-eyed understanding of what the difference we can make in people's lives.
Well, I really think that speaks to the stigma, even in people who believe themselves to be good, kind-hearted people who would bring the dinner in for the broken arm. I just think we need to do something to change the mindset around you should still take a dinner in if your neighbor's in need, regardless of what the diagnosis is, a physical or mental health issue. People still need the support. What I wanted to say about the family support, I'm lucky enough to have a staff that's housed in my office with me that is a NAMI employee, but works with us to be able to provide family advocacy to those families who really are struggling. So our case managers serve as far as like developing resources for whatever the child needs to be able to help address the mental health issues. But the NAMI advocate actually goes in and provides the support and the advocacy for the parents. Gives them support, gives them resources to help them cope. They have a support group that's offered out of our children's outpatient unit. When you interview parents and when we ask for feedback, they say that's one of the most helpful things they have is a woman who has walked in their shoes and can actually empathize with what them and their family are going through.
Dr. Gray, let me ask you, we're nearing the end of our time here together, and we hopefully you're calling in, requesting the information packet. We'll talk more about that one more final time. But over here we have the clearly documented human need. Over here we have clearly demonstrated successful treatment programs, and what is absent is the bridge that connects need to the demonstrated successful programs. How do we get that bridge in place? As you look at it as a working professional, how do we get that need met by the programs we know that can work?
Well, we either need insurance companies that sign us up for the long haul, so they're invested in us long term and they want us to be healthy so we don't cost more money down the road. Or we need a nationalized healthcare system and a nationalized mental health care system so everybody can have something that's good and reasonable.
And that's going to be terrifying people when they
Yeah.
look at it. Not perhaps the people in greatest need, but governments and decision makers say, well, that is just not, that's not right. But are we somehow missing an important connection, Sherry, if we say, on one hand, we want a strong, independent, capable healthcare system, but we're just not getting around to meeting human need?
Well, you know, when we don't treat mental illness, there's a serious impact on our schools, on our criminal justice system, the jails, our emergency rooms, our homeless population. We are creating a much more expensive problem by not treating it. It's critically important that we see that there is a need here that we cannot ignore. We are paying for it. And also that we, as providers within the community partners, better coordinate the services that we provide so that we can make the best use of the dollars we do have.
There is another sense that exists in the community that I've encountered from time to time, is that people who are mentally ill are somehow more readily disposed to committing violence, to being involved with criminal conduct and activity. How does that square against what we truly know about the realities of people who are battling mental illness?
So there's no increased risk of violence for any diagnosis except schizophrenia, unless you involve alcohol or drugs. That does increase risk of violence. But with schizophrenia, if you're treated, you're very safe. If you're untreated, there are people that, because of paranoia and delusions, can become aggressive. So the key is, you know, when we don't treat people, we have consequences to our society that are terrible sometimes.
I've been told I have 1 minute left. Do I have to close now, or do I? Okay, I have one minute left. So, Stacy, I got to come with you. If there's one attribute that we could infuse into our existing mental health care system to help start addressing human need, how would you define that attribute that you see missing now but necessary for the future?
I think a lot of people still operate on the premise that treatment doesn't work and that recovery is not possible for these people. And it is. And they, just like Dr. Gray has said and Sherry has said, treatment works. And when you can't treat the people that need it, then you run into the risks of what people already think about the stigma of these individuals in the community. So I think mine would be treatment works.
Okay. Thank you very much. My thanks to Sherry Whitwer, Dr. Doug Gray, and Stacy Brubaker for their time tonight. And this is a final reminder to call in for the free information packet on mental illness produced by KUED and our partners for this event. It includes the KUED documentary On the Edge and a variety of information sources and contact points to help you better understand treatment and response issues associated with mental illness in Utah. Each individual and each family creates a response to mental illness in their own fashion. Now, the experience in my family was like trying to feel our way down a darkened hallway. Some of the doors you encounter are locked and it can be hard to find your way. But for us, the simple will to keep moving and keep looking together eventually led us to an unlocked door and a source of life. 1 in 4 American families deals with the consequence of mental illness. Every region, every state, every faith, every income, every gender, every race. Mental illness is not someone else's problem. I'm Ken Verdoya for KUED. Good night.